Hello, everyone. Hopefully you can hear me. Um, Thank you for joining on a Friday afternoon away from the sun. It's a real pleasure to host everybody here today. I think what we'll do is we'll get going, and then if anybody joins later on, that's fine. Just double checking that people can hear me. I think I'll be alerted if anybody can't in the chat. So great. So I'll just share my slides and I think you should be able to see this. So my name's Hashim Ahmed. I'm a professor and chair of urology at Imperial College London. I spend half of my week doing research and the other half doing frontline clinical work in prostate diseases, both the diagnosis and treatment of prostate cancer, as well as benign enlargement of the prostate, and have spent most of my career trying to look at ways of improving the way we diagnose men with less harm and improved diagnosis and also when we treat men, whether we can do that with less harm than we are currently carrying out with surgery and radiotherapy. And hopefully you'll get a lot more information on alternative option of focal therapy today, which is the primary focus of this webinar. And I've got a few questions that people have written in, but if there are any other questions, then we'll take them at the end, if that's okay. You can post them through the chat feature, either anonymously or by yourself, and I'll just read the questions out. And I'll also put some contact details at the end for those of you who might want to have a more bespoke chat about your specific situation if there are questions outstanding. So we have learned over the last 2 decades that the old way of diagnosing prostate cancer was really pretty bad. And it's important to rehearse this, even if you know about this, because that has driven the reasons why we have followed the route of radical treatment rather than a minimally invasive approach. And the old pathway involved men with an elevated PSA, so a blood test that would be high, measured by their GP, and the GP would refer them into the urology department. And in most cases, that urologist would carry out a back passage biopsy with needles going randomly into the prostate, bang, 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 bang. It would take about 3 minutes. A lot of the times they didn't use local anesthetic. Be a horrible procedure, pretty bad experience. And whilst the urologist could see the needle and could see the prostate, in the vast majority of cases, they couldn't see if there was cancer in there, and if there was cancer, where it was. And so it was pretty random. And as a result of that, a lot of problems with the pathway. So we used to find low-risk cancers that a third of men have in their prostate and never know about. We used to miss high-risk cancers because we didn't know where they were in the prostate. And sometimes with a glancing blow on a high-risk cancer, we used to say it was low risk when actually it was high risk. And that man might go on surveillance. And because of all of these errors, because people knew there were these errors, if cancer was found, the treatment was to the whole prostate, because if you're going to treat it and you have no idea what the biopsy found or missed, then it was better to just treat the whole prostate. So I think prostatectomy and radiotherapy came out of good intention because the diagnostic accuracy of what we did was just so poor. And this way of diagnosis has been going on for decades until about 7 years ago when things really changed. And so now we know that even if there are 2 or 3 tumors in the prostate, It is one area in the vast majority of cases, not all cases, but there's usually one area which is the most significant, either the larger one or the one that looks more aggressive under a microscope. And it's that one which drives progression. Progression means the cancer getting larger, eventually invading local tissue or spreading. And those tiny other areas, the yellow dot on this prostate, were areas of cancer that would not progress. It's the sort of disease that if we took 1,000 men off the street above the age of 50 and looked at their prostates in detail, about a third of those men would have those tiny little areas of cancer that they would never know about. And if we started to chase those tiny little areas of cancer, then a third of men in the male population having radical prostatectomy or radiotherapy, it's nonsensical, of course. But when we find these areas of cancer, we then start getting worked up. So we want to find the important cancers that are likely to cause progression, metastases, and a shortening of life. And we don't want to find those tiny areas of cancer. But even if we do, we can, in a lot of men, target just the main area of cancer and monitor the rest. And some men do need then treatment to the untreated tissue because they develop something new, but a small proportion. So we understand the biology of the disease now much more, and we know that MRI scans, these are magnetic scans and targeted biopsies, can find these cancers that are likely to progress with higher degree of accuracy, 90, maybe even 95%. MRI tends not to see those tiny little low-risk cancers. Brilliant. We don't want to find those, but if we do find them, we know that they are tiny because the MRI can't see them. The MRI has a resolution of about 3.5 millimeters. And so we can usually tell that these are low risk, tiny areas of cancer. And a proportion of men can have minimally invasive treatments that are targeted to the area that is the index tumor, the tumor that is likely to progress. So this is an MRI scan. If you imagine a man lying on a table and you're standing at the leg end and you're looking up towards him lying on the table, and the MRI scan is taking salami slices of that man. And so what you're seeing is, oops, let me just get a laser pointer. What you're seeing is this is the back passage. This is the prostate. And this is the water passage just here. And this dark area is the tumor that can be seen. And this man subsequently had a biopsy, and that demonstrated an area of medium risk disease. And the reason I show this is that a lot of men with these tiny areas of cancer, which are medium risk, could actually be on active surveillance because these are slow growing tumors and in many cases don't grow for years. In fact, only about a fifth of men like this will see that their cancer grows, but slowly over a 5-year period. So if you have tiny amounts of cancer, even if it's medium risk, Gleason 3+4, you could have surveillance. There are other criteria. We need to make sure it's not too big. We need to look at something called the amount of pattern 4, which is often sometimes a difficult concept to get round. And I won't cover too much here, but there's other things that we need to look at to make sure you are suitable for surveillance. But it's important to keep in mind that surveillance, provided you don't disappear on us, provided you do the PSA blood tests and any other tests that we think are necessary, and keep on top of that and be proactive, change your diet, improve your health, it's very safe, and we'll do surveillance together. You won't be on your own. And that is the best way to avoid side effects of these radical treatments, which you'll learn about. So it's important that focal therapy is not seen as an alternative to men who would safely be on surveillance, and they should comfortably be on surveillance and not worry. So we can, when we diagnose, give a risk category to men. So again, just so that you have a bit of background, a man with low risk cancer will have a PSA of 10 or less, a Gleason score of 3 + 3 = 6, and the cancer will be contained in the prostate. And these men, on the whole, should be on active surveillance. In fact, 95% of men with low-risk disease in the UK are managed with active surveillance and very safely and comfortably stay on active surveillance over a number of years. If we find medium-risk disease, it means that the PSA is a little bit higher, so between 10 and 20, but it can be below 10 as well. And under the microscope, the cancer cells look a bit more aggressive. Not hugely, but a bit more aggressive. And they are scored a Gleason 7, which can be a 3 + 4 or a 4 + 3. And that just means when the pathologist looks at the slide of cancer under a microscope, a 3 + 4 means there's lots of low-risk cancer and a little bit of medium-risk cancer, whereas a 4 + 3 means there's more medium-risk cancer and a little bit of low-risk cancer. So that's what 3 + 4 and 4 + 3 means. It's the proportion of medium-risk disease under a microscope in the slide. And the cancer has to be contained in the prostate. And these men, the large proportion of men who get diagnosed, fit into this category. And they have a choice because these tumors are slow growing on the whole, and most of them could be managed with active surveillance. But if they would prefer not to, or if they show signs of change on active surveillance, then they might want to have treatment. And the treatment options are focal therapy, radical radiotherapy, or radical prostatectomy. And then finally, if you're diagnosed with high-risk disease, this means that the PSA is higher. So there's something in the prostate which is spewing out more PSA into the bloodstream. The cancer is more aggressive under the microscope. It's got a Gleason 8 or 9, rarely 10. And the cancer starting to invade into the edge of the prostate, or has already breached the edge of the prostate. And in these men, generally, we would want to carry out aggressive treatment. These are the men that if we don't carry out aggressive treatment, it could progress much quicker and cause a shortening in life. And so generally, men with high-risk disease can have radical radiotherapy, radical prostatectomy. There are some small high-risk tumors which are not going into the capsule. They have a PSA of 10 or 11 or maybe even 5 or 6. And we've caught it early. We've caught a high-risk cancer early. There's no sign of spread. Those men can have focal therapy as a way to avoid the side effects of radical treatment. Now, how do we carry out focal therapy? There are 3 ways in the UK currently that you can have focal therapy, and I'll try and explain what the differences are between the two. So high intensity focused ultrasound is a sound wave treatment. It doesn't involve any cuts, doesn't involve any needles into the prostate, and the pulses of sound waves are directed into the prostate with a probe in the back passage. And for those of you who, when you were younger, used a magnifying glass or a piece of glass to focus the sun's rays on a dry piece of leaf to make it burn, or a piece of paper to make it burn, the HIFU works in a very similar way to that. It focuses the sound wave this time, not sunlight, sound waves into a very small point, the size of a grain of rice, approximately. And in that area, the size of that volume, the size of a grain of rice, the temperature goes up to about 60, 70, even 80 degrees centigrade. And so each pulse can destroy tissue to millimeter accuracy. And what we do is we throw in lots of these pulses into the prostate in order to treat the cancer and a bit of surrounding tissue. So this is the HIFU probe in illustration. And we fire lots and lots of these pulses, hundreds of these pulses into the cancer. And we try not to be too clever about it. If you go too close to the cancer, your recurrence risk goes up. That's what we've learned over the last 10 years. And so we give it a wide field around the cancer. And if we treat, we can repeat the treatment if the cancer recurs. Now, cryotherapy, again, is something that is used to freeze cancer cells. We use it in tumors that can't be reached by the HIFU. So one of the common questions we get is, when do you use HIFU? When do you use cryotherapy? Well, in this example on the right, that tumor is much further away from the back passage. So the HIFU pulse only has a limited reach of about 3.5 centimeters. So if you have a large prostate and your tumor is really high up, then the HIFU will struggle to reach that tumor. And even if it can reach it, if it's going through lots of tissue, then all of that tissue can dissipate, can lower the energy of the HIFU. And so by the time the pulse reaches the tumor, some of its energy has been lost as it travels through deeper into the body. So what we've found, again, over the last 10, 15 years, is that tumors that are further away from the HIFU probe have a higher recurrence risk, and therefore, in those tumors, we are better off using a cryotherapy modality or a needle-based way where we image the prostate with a probe similar to the one that you would have had a biopsy for, and the needles go in through the skin behind your scrotum. It's called transperineal, very similar to what most biopsies are doing now. And the energy is delivered, the energy in inverted commas is freezing energy, is delivered directly into the tumor. So there's much less chance of the energy being dissipated by something. Neither of these are perfect treatments, because the nature of the disease, I'm afraid, is even with surgery, even with radiotherapy, HIFU, cryotherapy, some cancer cells somehow survive. Or there's something about the technique that was used that means we didn't quite cover everything. And there's a balance between covering the tumor and going too wide where we start to damage other tissue. And just to highlight what these points are, these are all the nerves on the side of the prostate. It's not one bundle. There are little nerves all along the surface on both sides. They supply the penis for erections. They also control the muscle that stops you from leaking. The water passage you can see is here. The back passage is millimeters away, as you saw from the MRI. So everything is very close, and you're working to the level of millimeters. And so you have to have a balance. And what I often say to men is, we're doing focal therapy to minimize side effects. And because I know I can go back in if there is a recurrence and repeat the focal therapy, with the first treatment, we want to obviously clear the cancer if we can in one go. But if I'm starting to get close to critical structures, I'll take my foot off the pedal, because I want to make sure you don't get complications or side effects. And hopefully we've cleared it, but if we haven't, we've got another chance to do so later on without compromising survival. The other focal therapy that has started to come out, which you'll read about, is something called irreversible electroporation or nanoknife. And again, similar type of cases that we would treat. And this is a electrocution of tissue. So we use a probe in the back passage to scan the prostate and direct the needles to the right place. And then this is an error on here. We put needles into the prostate to target the cancer. So a lot of the tumors that are suitable for cryotherapy are suitable for nanoknife, although larger tumors are probably better treated with cryotherapy rather than nanoknife. But there's a bit of an overlap as to which type of tumors can be used for nanoknife and cryotherapy. And it depends on what your local urologist and surgeon wishes to do. So here we're putting needles in again into the tumor and around it, and this time using electrical current, high voltage electrical current between these needles that causes the tissue to die effectively through electrocution, because we're disrupting the cell's membrane and they sort of open up and split open and die that way. There is a bit of a heating effect as well. So there's a heating effect and the electrocution effect. This might be one of the more important slides. It's got lots of information, but it tells you what the broad criteria are for being eligible for focal therapy. And often, if you see your biopsy reports, you can't quite work out what's going on. And I will do a video for men in future, but up until that moment, if you need bespoke advice, I'll show you where you can get that, because when you get your biopsy report, you have no idea what it means. People use different nomenclature. They talk about right medial, right lateral, right anterior, right posterior, right mid, right paramedian. We're in medicine, we use nomenclature and jargon like any other profession does. But broadly speaking, if you have a medium risk or a small high risk tumor on one side, then we can treat that tumor even if there's a small amount of low risk disease on the other side. And low risk disease can be up to 5-6 millimeters of Gleason 6 disease. But the MRI must show that there's nothing going on there. Sometimes we have referrals from other centers where we see something on the MRI that hasn't been biopsied. And so we might say, look, we can't offer focal therapy until we repeat the biopsy to clarify what's going on. And so we sometimes have to do that to clarify what's going on. In a small number of cases, we can treat two areas of cancer, but we have to be able to see where those areas are and accurately localize them. Otherwise, we could end up treating a whole quarter of the prostate just for 2 millimeters of disease, which just doesn't make sense. So I often get asked, well, why can't you just knock out both? Well, actually, it's easier to knock out the bigger tumor than it is to knock out that 1 or 2 millimeters that was found on some random biopsies taken from the other side. And in order for me to treat that, first of all, there's no need to treat it at this moment in time. If that's all we found in your prostate, then we wouldn't treat you at all. And secondly, I have no idea where that 1 or 2 millimeters is. You had biopsies just taken randomly from the rest of the prostate. And thirdly, the more tissue we treat, the more side effects there are. So there is a balance. And if you've chosen focal therapy, it's because you want to have your cancer treated, but you want to have the minimal effect on your side effects. So what can patients expect after radical therapy? And so if you had surgery and had the whole prostate removed, in this instance, this is the prostate, and this is the tumor up here. This is the back passage. These are the seminal vesicles, which secrete fluid that nourish the sperm. You can see the hip joint here and the hip joint here. So if this man had whole gland treatment, remind yourself that there's nerves all along the side of the prostate on both sides. The water passage is here. Look how close the back passage is. The bladder's behind the screen, connected to the prostate, and the muscle that stops you from leaking urine, part of it is actually inside the prostate. Part of it comes out of the prostate, and so that can get damaged as well. So really critical structures, very, very close, if not on top of the prostate, some of which are inside the prostate. So again, some people are shocked by these numbers. These are numbers based on studies in the UK, internationally, and from large studies from the literature. And nobody can argue about these figures, but you, if you're a patient logged into this, might not have been told that these are the figures. But this is what the reality of the figures are. So urinary issues like frequency, rushing to the toilet, getting up at night, is this line here. It's more common with radiotherapy because radiotherapy causes an irritation of the water passage and the bladder. Incontinence of urine, where you leak urine and you need to wear pads, is in the latest UK robotic prostatectomy series. Of all the major robotic prostatectomy series, showed that it was 35%, so a third of men were wearing at least one pad a day, long term, in the first year to us. With radiotherapy, it's a different type of leakage. It's where you rush to the toilet and you can't get there in time. It's called urge incontinence. With surgery, it's more likely to be stress incontinence. You cough, you sneeze, you lift something, you bend over, and you leak. Some men just leak all the time because their sphincter is just not working at all. Erection problems, again, these are actually an underestimate. So the latest UK study shows that it's probably in the order of 80 to 90% of men have erection problems, which are insufficient for penetrative sexual activity, even when taking Viagra or medications like Viagra. And they need to use injections or vacuum pumps, and a minority need to actually have an operation called an implant surgery in order to get their erections, if they want to go down that route. So these are underestimates. For some men, ejaculation is important. It's an important part of being a man and their sexual activity. And with both of these, you lose ejaculatory fluid. Back passage problems are not that common after surgery, but with radiotherapy, you can get bleeding, regular bleeding, loose stools, urgency to pass stools, discomfort in the back passage, and anywhere between 5 and 15%. And it depends on how your oncologist defines those side effects. If they define them as severe side effects, they'll quote you 5%. If they tell you about moderate or even mild side effects, then it's at least 15%. Another common misnomer from patients, and often not corrected by physicians all the time, is that once the prostate is out, there won't be a recurrence. And I'm afraid that's not correct. So about 15% of men after surgery will have a recurrence. And that's because when you do the act of surgery, you're pushing, you're prodding, and some of those cancer cells can spill out. The prostate is not like an orange. So when we talk about the capsule, it's not really a proper capsule like you would get around an orange, the pith. It is just the inside tissue, inside of the orange, and then it's the rest of the tissue. So when a surgeon is doing surgery, if the cancer is just on the edge of the prostate, the pushing and prodding can sometimes make cells spill over. Sometimes, because surgeons want to make sure they don't cause too much damage, they go close to the prostate and they can cut into the tumor, and that's called a positive margin. And that can lead to a higher risk of needing to have radiotherapy afterwards. And then radiotherapy, some of these cancer cells, it's the nature of cancer cells, I'm afraid, that there's no one thing that can kill all cancer cells. And some cancer cells are resistant to radiotherapy effect. They create pockets inside the tumor which are resistant to that DNA damage caused by radiotherapy. And again, about 15% of men will have a recurrence after radiotherapy. I won't go to too much detail about what happens when you have recurrence in these settings, but there are differences in that if you have radiotherapy, it's much more difficult to remove the prostate. It's much more difficult to do things like HIFU and cryotherapy, although not impossible. With most cases of cancer, the prognosis is good. Almost all men will survive 10 years and beyond. We stop measuring data at 10 years often because in the past, the survival life expectancy for men was no more than 75, 75 years. So why bother? And when the average age of diagnosis was 65, 66, we didn't really need to go beyond 10 years. So a lot of men and their families say, well, what about 15 years? What about 20 years? We don't have great data on that. So if we did focal therapy in this same man, we would be looking at targeting the tumor. We will give it a wide berth. So we'll treat a few millimeters, about 5-6 millimeters beyond the tumor edge as defined on the MRI, partly because we can sometimes have swelling and movement during the treatment. And if you're trying to be too clever about getting right onto the tumor, you can miss the edge of it. Partly also because the MRI can sometimes underestimate the extent of the cancer cells. And we know from studies that there are a few stray cells just beyond the edge of what the MRI is showing. So we want to incorporate all of that into one go. So as you can see, a marked difference, 10 to 20-fold lower risk of side effects on almost all of these areas. So urinary issues in the long term, you will get some urinary issues in the first few weeks. So there is always a recovery period. We're causing damage to the prostate. The body's healing that area. Everything is going to be sore and inflamed. It takes about 6 to 8 weeks on average for those symptoms to settle down. These are what we call the long-term side effects. And so long-term urinary issues, which are significant and quality of life affecting, is about 1%. Incontinence, so leakage of urine, is 1% or less. And we will know that by 6 to 8 weeks, 2 to 3 months, that sort of time period. So there's a quicker recovery as well. Risk of erection problems really depends on how bad the erections are or how good the erections are before treatment. So if you're already taking medication and it's a bit of a struggle, you're going to be at the higher end of that range, 15 to 20% chance, although you still have a better chance than if you had surgery or radiotherapy. And if you've got really good erections, no need for medication, you're going to be at the 5 to 10% range. So that's what that range means. And this is defined by ability to have firm erections for completion of penetrative sexual activity, with or without medication like Viagra. So very few men need to use injections. I think in the last 10, 15 years, I haven't seen a man yet who needs an implant surgery. And interestingly enough, about 60% of men will have fluid when they orgasm. So there's a pretty good chance that they won't, 40%, 50%. And in those men who do have ejaculatory fluid, it will be more watery and there will be less volume. For those where it's relevant, it's important to note that you could still naturally conceive children because there may be viable sperm in that ejaculation. So just be careful. Back passage problems are very rare. like with surgery, much lower than radiotherapy. And as I sort of hinted at before, about 15 to 20% of men, slightly higher than surgery and radiotherapy, will need to have further treatment. The critical difference is that that further treatment can be focal therapy again. So if you have cryotherapy and the tumor, there's a little bit of tumor that is seen after treatment at 1 year or 3 years or 5 years or 6 years, whenever it is, in the same area, we can do cryotherapy again. And that second cryotherapy has another 80% chance of success. And so overall, only about 5 to 10% of men need to actually switch to surgery or radiotherapy. The other way you can have a recurrence is we've left tissue untreated. Up to 50% or 3/4 of your prostate will still be there. And our data shows from thousands of patients that about 1 in 20 men will develop a new significant tumor that needs to be treated. In the majority of those men, they choose focal therapy again. But some of them say, well, actually, it's a new tumor. I've had a good 4 or 5 years of good function. I think it's time to deal with the whole prostate. And that's fine. We will support you. We'll get you to the right experts to do that. The surgery and radiotherapy is feasible. You don't burn your bridges, but there is going to be a little bit more scarring around where the focal therapy was done. The surgeons don't struggle around that area. They just comment that it's more scarred, and the outcomes so far look pretty good. And then, as you can see, survival, as you'd expect for the group of men that we treat, is really good. So the adage is it's not whether you will get there, it's how you want to get there in terms of side effects and treatment. And this is just to show you, we did a comparison of surgery versus focal therapy. This is a graph with time across the bottom axis and the proportion of men that who don't have a recurrence, so failure-free survival probability. And the salmon-colored line is focal therapy, HIFU or cryo. The light blue line, teal line, is prostatectomy. And as you can see, the two lines overlap. I wouldn't read too much into one line being higher than the other. So the higher the line is, the fewer the recurrences there are. So that's what this graph means. Both lines overlap effectively. And we've done a similar study comparing surgery, radiotherapy, and prostatectomy. And again, we've found a very similar pattern, very little to no difference between recurrence, metastases, survival. So far, the outcomes look really good. What we don't have is a big randomized control trial. We've tried to do this, but men, when faced with the choices of focal therapy or radical treatment, they often choose focal therapy and would prefer not to leave it to a computer to decide which one to have. So having a randomized study would be really great, but it's been tough to deliver one. And I know there's one recruiting at the moment called PART, and we'll see if men are willing to take part. So focal therapy is approved by NICE, but it's approved through what's called the Interventional Procedures Guidance. There's another scheme called the Clinical Guidance, and that simply says research or see the IPG guidance. So it is approved through NICE, but they've stipulated that we must continue to look into this treatment because we don't have, 10 to 15-year data yet. We should continue to do research, which is great. We must discuss every case at a cancer multidisciplinary team meeting to make sure I'm telling you the right thing or my colleagues are telling you the right thing. We must discuss all of what I've just discussed with you in terms of side effects and recurrence risks and the lack of 10 to 15-year data. That must be made very clear to every single patient. and we have to continue to collect our data. And we're in a lucky position in the UK where we collect all of our cases and we publish every 2 or 3 years updates on that data. There are a number of NHS sites offering it. So if you are self-pay, you shouldn't worry about a delay of getting a referral. There's plenty of time to consider your options and get a referral into one of these NHS centres to get treatment on the NHS. You are entitled to have that unless you're in Scotland, in which case they block referrals, I'm afraid, to England. Wales, you have to get prior approval, but it's often granted. But in the rest of in England, you are entitled to get referred to a focal therapy centre, either by your consultant, who can email or write a letter direct to the consultant at one of these centres. Your GP can also refer you through the electronic referral system, but it has to be done through the electronic referral system. If one of these centres is not on their electronic referral system, it's because the local commissioning board, commissioning group has removed out of area referrals. In that case, if your GP writes a letter to one of these centres, it should be accepted. The waiting times for a clinic appointment are generally up to a month. There are some delays, and that's often because when the referral comes in, the biopsy report's not on there, the MRI report's not on there. We then request the images. We need to see the actual images. We can't base it just on the written reports. We need to see the images. Often things are not quite right. We sometimes have to repeat the MRI. Sometimes we have to repeat the biopsy. It would be wrong of us to base a consultation without having the full information. So that's why sometimes there's delays, because we don't often get everything from the referring centre. And I often will tell patients, just go to the department, go to the hospital, and don't leave until they give you that disc or give you those reports. You have to be proactive, I'm afraid, if there's delays. And then the treatment on average is about 3 months. We're trying to get that down, but it's not clinically relevant. I know it's really anxiety provoking and you get nervous and you get worried, but 3 months, 4 months, 5 months, 6 months is clinically not relevant. So if you want bespoke information on your specific case, and please pass on these details to anybody else who might ask, the prostate charity is run by a gentleman called Paul Sayer, who had focal therapy. He's very neutral. He will just give you the information. They will do a quick check that you are potentially suitable, and they have access to a group of us consultants where they can just ping off a quick WhatsApp or an email to us and say, can you just please have a look, see if there is potential suitability for focal therapy. And please get in touch with Paul Sayer or his team using those contact details if you're not sure. You can probably look at your own reports and work out whether you might be suitable based on this webinar, but if you're not sure, just you do need to get your details though. You need to get those reports off them. Don't take no for an answer. Don't say, oh, we don't when some men are told, well, we don't share the information with you. No, that's not true. You have the right to see it. You might have to formally request it, but it's a bit silly. Most consultant teams will just print things out and give it to you. And just because you go through the process and you might be potentially suitable, sometimes we will look at the images themselves, which we're not able to do using this process, I'm afraid. We do need you to come in to one of these focal therapy centres for the actual images to be reviewed. And sometimes we find that things are not quite right, and either the MRI needs to be repeated or the biopsy needs to be repeated, or it doesn't look suitable at all. Great. I will stop that and then go on to, sorry, let me just stop sharing. And then there's some questions. So I'll just go in order. I would like to know if I could be eligible for focal therapy, as I was told my 7 samples from my biopsy were found in different areas of my prostate, and no doctor is yet to tell me if I could be eligible. I think it's important that although the 7 samples might be from different areas, it's possible that 5 or 6 are actually from the same side and represent the same tumor. And 1 or 2 of the samples are from the other side, which might have low risk disease. So so if you remember, I said it could be that there's one index tumor and one tumor which is tiny, low risk. You could still be suitable, but it does need a detailed look at the biopsy report. Get in touch with Prostate Charity. If you have your biopsy report and your MRI report, send it to them, and one of us consultants who do focal therapy will be able to look at it. It might even be me, because Paul has access to the network of focal therapy surgeons. What is the difference between HIFU and cryotherapy? So I think I've explained in my webinar what the differences are and why we use them, and the difference between electroporation and HIFU and cryotherapy. The success rate when we use it in the way that I've outlined is the same. So about 1 in 5 men will have a recurrence. Might be 2 years after their treatment, might be within a year, might be 4 years, 6 years, but the 1 in 5 will have a recurrence and need to have further treatment. The vast majority of those men who have a recurrence in the same tumor that we've treated will choose to have HIFU or cryotherapy or electroporation again. Sometimes we chop and change. So sometimes if we do HIFU, we might do cryotherapy afterwards, because the anatomy of where the tumor is and the way the prostate has deformed, it might be better to do cryotherapy, or it might be better to do HIFU after cryo. But that hopefully answers your success rate question. Again, about 1 in 20 men still have a recurrence afterwards, unfortunately, and then need to switch to surgery or radiotherapy. So my PSA is rising, and I've been offered radiotherapy. So potentially you could have HIFU. Hopefully the webinar has explained some of the details of whether you might be suitable. If you've got access to your details, you could cross-reference them against what I've said. If you wish to share the reports and full details, again, that bespoke concierge service that the charity offers will probably be able to give you a more definitive answer, or a closer to definitive answer, if you wish. Can one have focal therapy if I've had full non-nerve sparing prostatectomy and the PSA is rising and the option is now radiotherapy? So we did a handful of cases like this, and I'm afraid the outcomes are hugely variable and unreliable. And the reason for that is because we can't often see where the recurrence is when we do the HIFU. So unless we can see it very clearly, what are we targeting? And that's why radiotherapy to what we call the prostate bed, or the space left behind after the prostate's been removed, is the best option in this scenario. And you should definitely, if you've been told that this is the option, you should definitely go down that option. The alternative is hormones, which again, depending on whether you're willing to accept the side effects of hormones or not, it is up to you. But radiotherapy in this scenario is the best option. Next question. I have a friend who has a Gleason score of 3+4, told very early stages after active surveillance. He has only been offered prostatectomy and has not been given any information on focal therapy or radiotherapy. How do I get him a referral? So it's really important, and I'm really disappointed in my colleagues time and again who see patients who need to have treatment. They've reached the stage where they need to have treatment, and they're not being told. And I really get very annoyed about this. Men deserve, and their family deserve, to know what their options are. And they may not wish to have focal therapy or radiotherapy or brachytherapy, but they must be told. It's part of our informed consent. It's your body. It's not mine. It's your body. And you have a right to know. And you're not there to make up the numbers on the robotic prostatectomy list. You're not there to make the business case add up for a new robot or for the existing robot. It really angers me when patients are not given the full options. So it might be he's not suitable for radiotherapy for other reasons. You know, sometimes if you have inflammatory bowel disease, it's best not to give radiotherapy because the bowels flare up. It might be that there's other reasons for why radiotherapy has not been offered. In very young men, radiotherapy may not be a good option because young men are going to survive 2 or 3 decades, and we know radiotherapy can, in a tiny, 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 tiny proportion of men, increase the risk of tumors in the bladder or in the back passage. But for the average man, that's just not a relevant factor. So there may be reasons why radiotherapy wasn't offered. Certainly, focal therapy not being offered as an option is quite a common theme. We know that 12,000 men in the UK are eligible for focal therapy. Only about 1,000 are having it. The main reason is not because they don't want it, is because they're not being told about it. And you can probably read into why I think they're not being told about it. There are some academic legitimate concerns that we don't have long-term data, some recurrence cases, but generally it's because people are protecting their turf, and it's just the wrong approach to have. Okay, next question is, if you've had HIFU treatment and the cancer comes back aggressive, can you perform the same treatment again? So there are some rare cases where if you've had one treatment, and it's not just HIFU or cryo, it can be radiotherapy and surgery as well, and the recurrence comes back much more aggressive. It's quite rare. And if it does come back more aggressive, if it's a tiny amount and we're sure that there's no spread, yes, you could have HIFU or cryotherapy to that same area. Again, just depends on the anatomy of what's come back, the size of that aggressive tumor. Is it extracapsular? Have we done enough to make sure that there's nothing else going on? So theoretically possible and often possible. Again, if you'd like to have further advice on a specific situation, very happy to offer it. Next question is, how long does a focal therapy surgery last? How long does a patient have to wear a catheter after focal therapy? And I'll come on to the BPH issue in a bit. So on average, an hour and a half, general anesthetic. We don't like to do it under spinal or sedation because you can fidget. And if you have a spinal, if you start coughing or if you start moving your upper body, that can move your lower body, even if you're completely numb down there. And remember, I said this is precise millimeter precision surgery. We can't afford you to move. So you need to be fit and able and willing to have a general anesthetic. It's an hour and a half on average, can sometimes be shorter, can sometimes be 2 hours, 2.5 hours. It depends on how much tissue we're treating. Afterwards, you will have a catheter through the penis into the bladder, and that's because the prostate swells up and causes pressure on the water passage. And if we didn't put a catheter in, you wouldn't be able to pass urine, and you'd have to get blue lighted in to A&E, and that would be horrible. The catheter, I'm afraid, is the one thing that most men don't like and come back and say, look, that was the worst part of the recovery. What can we do to not have it? It is necessary. There's not much we can do to stop having a catheter, but we appreciate it's not nice. The catheter stays in for about 7 to 10 days. Sometimes we ask for it to stay in for longer. Sometimes there are delays in the NHS in getting capacity to remove the catheters. But it should stay in for 7 to 10 days. For those of you who travel from far away, who come into London, if you can convince your practice GP or your local urologist to help out in removing the catheter, then you will have to arrange that yourself, I'm afraid, because it's quite difficult for us to speak to too many different people about catheter removals. We will remove the catheter for you in London if you're willing to come back, or if you have no choice but to come back because the local team either refuses or you're unable to get a hold of them. After the catheter is removed, it takes about 6 to 8 weeks for those urinary symptoms to settle down. A bit of burning every time you pass urine, easily controlled with ibuprofen and paracetamol, which you must take for a month. We give you antibiotics for a week to reduce the risk of infection. And you get symptoms like frequency, rushing to the toilet, getting up at night more frequently. And each week gets better, but it does take about 6 to 8 weeks to settle down. And then maybe another 6 to 8 weeks to get back to a steady state, almost normal type of approach. Erections do take a bit longer, partly because men are less active in the first few weeks. There's no reason why you can't be sexually active, but it will be a little bit sore. The quicker you can return back to sexual activity. I often say, very open about how I talk about this, is you should try on your own first. Get that confidence back, get the function back. If you need to take tablets, start taking tablets from about week 6 to get the strength back and get your confidence back before trying with a partner. Because often it's psychological as well. And then last question on here is HIFU can often be, I have heard the HIFU can also treat BPH. So in the UK, we don't do this. In the US, some practitioners are starting to treat BPH with HIFU. We don't really know how good it is, and whether it's as effective as some of the other treatments out there, and what the side effects are. One of my colleagues, Martin Connor, an early career researcher, one of the leading upcoming lights in urology research, so look out for his name. He's working up a study in using HIFU to treat BPH and compare it against standard treatments. So we'll see what that shows, but we won't be offering it freely to everybody until we do that study and we make sure that it's the right thing to do. Good. I think we are done with the questions. Thank you all for joining. I wish you the very best. Like I said, please do get in touch with Prostate Charity and just to pitch for them. They work really hard. If there's any way you can support them in other ways through donations or fundraising, if you have a friend who might be willing to donate or help or support them in any way, I really encourage that because they're doing a sterling job in getting the message out. But as I said, about 10,000 men don't even know that this treatment exists. So getting that message across is a real challenge every week, because every week we diagnose hundreds, thousands of men, and they often go straight to treatment, aren't told about these options, and they're so worried they don't think, they just go straight ahead with whatever treatment's been offered them. And we need to get the message out to as many of them as possible. All the best, take care, and thank you again for joining.